I am Dr. Arushi. I am pursuing my MD in dermatology. I'm a final year resident and I go by the name of Passionate Dermatologist on YouTube and Instagram. So, in case you want to see more of my content, that is where you have to go. So, today we are going to be doing a few questions a few questions that have come in the INI-CET and the NEET exam. So we'll start with a very commonly ignored topic, which is lab diagnosis. So there are a few tests that we do on the bedside of the patient to diagnose various dermatological diseases. The first one is Zank smear. So you might, if you have gone to the derma ward, or even if you haven't gone and you've just seen patients in derma, you might have seen that there are few people or few patients who get blisters on their skin. Now, when such blistering diseases happen, we have something, we'll discuss the blistering diseases in detail today, but there's something called Zank smear that we do on the patient's bedside. So we basically burst these blisters, and then once we have de-roofed them, there is a base which is filled with fluid that we get. Now we scrape it with the blunt side of the blade and we smear the material that we get on a glass slide. And then we stain the glass slide with Giemsa or Wright's or toluidine blue, and then we see it under a microscope. So the thing is, usually, how skin cells are supposed to be like. So if you see, basically, skin has three layers. There is epidermis, there is dermis, and then there is subcutaneous tissue. In epidermis, we have five layers. In case you don't know it, there is a mnemonic for that. Can little girls speak German? Okay, so C is corneum, L is lucidum. These are all layers of epidermis. So skin has three layers: epidermis, dermis, and subcutaneous tissue. And epidermis has five layers. For those five layers, we have a mnemonic. Can little girls speak German? G is germinatum. Then S is spinosum. Actually, G is granulosum if you see in the sequence. And germinatum comes at the bottom. So the thing is, all the cells of the skin are attached with each other. The cells are not present just like that. One cell is connected to the next one. So suppose cells are not like this. They're attached to one another and they're pulled towards each other by various proteins, which makes them slightly hexagonal, polygonal in shape. So the cells are like this. But if one of these proteins is not there, then what will happen is the cells will go away from each other. I'm going into the detail of blistering diseases. We'll be discussing this in a lot more detail later on. But then, so if one of these proteins is not here, if the proteins are there, the cells will be arranged like this. But if the proteins are not there, the cells will be detached from each other and they'll become round. That is called acantholysis. So in Zank smear, you might see acantholytic cells. That happens in a disease called pemphigus. If you've not understood this properly, we'll be discussing it again when we do the blistering diseases. But there are multinucleated giant cells also that you'll see when you de-roof the blisters and you see the bottom. In case of diseases like herpes simplex, herpes zoster, and varicella. So acantholytic cells are seen in pemphigus, multinucleated giant cells are seen in herpes, varicella zoster, and other diseases like that. Now there's another test called patch test. I'll show you a patient's picture and there you will be able to understand it better. So what happens is we basically take a few antigens and we put them on the patient's back. So you can see that there are few antigens that have been put on the patient's back here. And there was no reaction to either of these, but there was a reaction to this one. So when we put the antigens, we know what antigen we are putting where. So we can, once we read it, once you apply it 2-3 days later, the MCQs come around this only. When you apply it, it is removed after 2 days. So you read it on the third day, and sometimes it is read after 96 hours. So these are the 2 points that you have to remember. You'll be putting antigens, then you'll be removing them, and then you'll be taking readings. So in case there is erythema, oozing, crusting, or if there is an allergic reaction to a particular antigen, you know that that particular antigen is causing problem in a patient. So one of the questions that came in INI-CET 2019 was patch test is read after. This is a completely fact-based question. 48 to 96 hours, but this is something that you have to remember. And this is what patch test basically is. So you will apply antigens, you will tape them here, and then you will remove them and see them after 48 hours, and you will also see them after 96 hours. So these are the two time lines that you have to remember. And there might not be reaction to a lot of antigens, but if there is a reaction to one of those, you know for sure that this is causing allergy in the patient. Now, there's a question on KOH mount. KOH mount again is a bedside test. So basically what you do is, if you're suspecting fungal infection in a patient, you will just scrape either their skin, I mean the lesion, or you will take a scraping from the nail or any other body part from where you're suspecting that, whatever part you suspect has fungal infection, you'll take a scraping from there, and then you will put that scraping over a glass slide and you'll put 20% KOH over it. After 20 to 30 minutes, you will see under the microscope. So you have to leave it for some time before you start seeing it, because you have to dissolve a lot of things, and thereafter the fungal hyphae will become more prominent than the rest of the things in the slide. So fungal hyphae and spores will look like this. So this is a skin scraping and KOH mount which shows fungal hyphae in a dermatophyte infection. Now, this was a question that came in INI-CET May 21. A boy presents with patchy hair loss, itching and erythema over the scalp, which would help in the diagnosis. So, split skin smear is something that we do for leprosy. We take, if this is your leprosy patient, we'll take 2 samples from the earlobes, one from whatever part of the body we think has the lesion, and then we'll see it. So, split skin smear basically is again a bedside test that you have to know about, and it's done for leprosy. Gram staining is done in case you're suspecting a bacterial infection. But how do I know that this is not bacterial? Bacterial infections usually, they have pustular discharge. So we do not have something like that, and they are also painful more than itchy. So I wouldn't suspect a bacterial infection or something like that here. Then biopsy, again biopsy you do when you're clueless. When none of the other things work, that is when you go to biopsy. But if you can rule out something with the bedside test, that is better, no? That should be your first approach. So KOH mount is a bedside test. It's very easy to do. You just have to take a scraping. You have to put 20% KOH over it, and then you have to see it after 20 to 30 minutes, or in case you're doing it from a nail clipping, you have to leave it for 60 to 90 minutes. So basically, in this question, we had to do a KOH stain. I hope this was clear. Then there was a question. See, I think this was a very recent one. You had to match the Woods lamp finding with what you see when you place the Woods lamp over a particular area. So the thing is, this is a Woods lamp, first of all. Second thing that I want you to notice here is that there are a few mistakes with the image. First thing is, Woods lamp is a procedure that is done in a dark room. I am not doing it in a dark room. Then you're also not supposed to wear white clothes. Some people say that they reflect light and all, and it interferes with the result. So white clothes like these are not very conducive to the findings of Woods lamp. Anyways, so the thing is, Woods lamp is, there are few MCQs that come around Woods lamp. The first one is, what is it made of? So it is barium silicate 1%. It's made of barium silicate. Wait, I don't. Yeah, it contains barium silicate. We do not need the percentage here, but 9% nickel oxide. So N for 9, nickel oxide is 9%, and barium silicate. So these are the two things that you find in a Woods lamp. And then you also need to know the wavelength of the light that it emits, and it is 365 nanometers. So 365 nanometers, and it uses barium silicate and 9% nickel oxide. Now the question was, how do various things look under a Woods lamp? So erythrasma will look like, it will give a coral red color. So you can see that it's coral red here. Tinea capitis will be greenish. Then vitiligo will be bluish white. So you can see that it is appearing just like that. You have to, at the end of the day, you have to basically remember this. But then erythrasma, you can see that erythrasma is red only. And then fungus is green, fungus is like a plant thing only, Matlab, it's green. We usually see fungus in real life also, it's green only in color. And then white, vitiligo is actually white only. So it's not too much of a task to remember this, but then you have to remember them at the end of the day, otherwise you won't get this question correct. you won't be able to mark it correctly in your exam. P versicolor is yellow. That was another option. So you basically had to match the findings of Wood's lamp with what you saw under that lamp. Okay, now we'll take some questions from nail. So again, nail is very, it's very easy to understand, and it's also very easy to predict what all they'll ask from nail. Firstly, we'll start with the anatomy of the nail. So this thing is the nail plate. This big thing that you see, this structure is the nail plate. After that, these are the nail folds. So these are the lateral nail folds, and this is the proximal nail fold. So these are both nail folds. Then there's this thing called cuticle. Can you see? I don't know if I can help you see it, but this thing. So cuticle basically glues the proximal nail fold to the nail plate. It's like a glue. It's a very transparent thing, and it's present like this over here. So if this is your nail fold, in between that you'll have this transparent structure called cuticle that will help you glue the proximal nail fold to the nail plate. Now there was a question on acute paronychia. It came in my NEET exam. I remember that it came in my NEET exam. So basically, they had asked about the medicine that you have to use when you get this infection. So basically, acute paronychia is a nail infection. It is a bacterial nail infection. It happens due to Staph aureus, and you have to give anti-staph medicines, which are mainly erythromycin and cloxacillin. Again, you have to remember this. There is, they asked it in the recent 4 to 5 years only, so there is a good chance that they might repeat it again. Anyways, then there is chronic paronychia. So there is one very interesting thing about chronic paronychia. See, all acute infections are usually bacterial and they're usually staph. Chronic infections are fungal. They can be candida, but along with that, there is a component of chronic inflammation. So when we treat this, we not just give medicines for candida or for the infection, we also give mild steroids. That is the complete treatment. So just in case, because they've asked acute paronychia, if they ask chronic paronychia, not just a topical azole or like a topical antifungal, a better answer would be the one which also has like a mild steroid with it in the options. Now it happens when people do a lot of wet work, thumb sucking, diabetes, manicures which destroy cuticles. So you can see that acute paronychia is easy. You just have pus filled in this area. But in chronic paronychia, there is a loss of the cuticle, there is a swelling of the nail folds. You can see that the nail plate also is so destroyed and all. So chronic paronychia is not just infection, there is also an element of inflammation that goes on, and you have to treat accordingly. Now we'll discuss something called onychomycosis. Onychomycosis is when there is fungal infection of the nail plate. So nail plate will be yellowish in color, it will become thick, and below the nail plate you'll be able to see hyperkeratosis. Those are the three findings that you see in fungal nail. Now what happens is you can have a distal lateral subungual onychomycosis. So this is distal and this is lateral also. So distally and laterally you could have an infection, or you could have an infection proximally, or there could be wide superficial infections. There could be total dystrophic nail. So the complete nail could be damaged. There could be distal and lateral damage. There could be proximal damage, or you could just have wide superficial spots on the nail. So that is what happens in onychomycosis. Now the next thing that I'm going to discuss is a very important MCQ. They keep asking it every alternate year, so I really want you to understand this very carefully. Now there's something called a psoriatic nail and the nail of alopecia areata. The way I remember it is alopecia areata in its name itself has this symmetry. So the pits that you see are also symmetrical. Okay, that is one clue. But other than that, you have to remember that the nail pitting, psoriasis is a disease that we'll discuss later. Then there was a question on for Staph aureus, we use vancomycin. So the thing is, yeah, you can use vancomycin for Staph aureus, but the thing is, we mainly use it for MRSA. So vancomycin is an IV drug. For a small infection like paronychia, if you can manage it with an oral medicine, why would you want to give something that goes IV? Also, we use vancomycin for resistant strains of Staph aureus. So in case like the vancomycin is the option you might want to pick that up. But if you ask me as a clinician, I would not want to give vancomycin because it's an IV medicine and I would want to go for something that's oral. So like I said, cloxacillin and erythromycin are better choices here. Now this is a very important MCQ. It is asked in NEET every alternate year. You have to differentiate between the nails of psoriasis and alopecia areata. So alopecia areata, as you can see that it's a very symmetrical molecule. Alopecia areata, it's symmetrical in the name itself. So the nail pitting also will be symmetrical. That's one clue. Other than that, you have to remember psoriasis is a disease that we'll discuss at length later. Psoriasis is basically a disease where you have plaques formed over the body. There are round lesions all over the body. They're scaly, they're silvery, and they keep happening, they keep disappearing, and they keep appearing. So that happens in psoriasis. We'll discuss it later. But the thing is, how do the nails in psoriasis look like? The mnemonic for that is riddle. Random, irregular, deep, and large. Okay, so randomly arranged, deep, large pits you can see on the nail. And alopecia areata is just the opposite. There is no randomness, there is symmetry. They are not irregular, they are regular. They are not deep. You can see that they're very superficial. Then they're not also large. You see, there are very small pits that you can see over the nail here. So basically, the nails, but the difference of the nails, extensor plaque. Yeah, you see plaques over the extensors as you're saying med world. You're correct. You've correctly mentioned that you'll see plaques on the extensor surfaces in psoriasis. And as far as this mnemonic for the nails goes, you have to see that you have to remember that psoriasis has random, irregular, deep, and large pits, whereas alopecia areata has symmetrical, regular, superficial, and small pits. Now there was an MCQ, 25-year-old female with paronychia of the little finger. The image is not that good, okay, but then I showed you how paronychia looks. This is how paronychia will look, this particular image. Now if that comes in the exam, this was the question in one of the NEET exams. 25-year-old female with paronychia of the little finger, with the given finding came, what is the suitable antibiotic in this case? So the suitable antibiotic would be the one against staph, which is amoxiclav. Now, a patient with the following nail changes on examination, nail pitting, subungual hyperkeratosis, and oil drop pigmentation came to the OPD. What could be the diagnosis? As I've told that psoriasis is a disease that we'll discuss in detail also because it's a TND, so I assume that you guys know what psoriasis is. But then there are certain things that you see in a psoriatic nail. This is an oil drop. This looks like somebody has put like an oil drop or something over the nail. This is called oil drop sign. Then you also find pitting, as I've shown. This is the kind of pitting that you'll see in psoriasis. Besides that, there are other things that you'll see in a psoriatic patient. So, leukonychia, the nail can become white. Subungual hyperkeratosis, the nail plate can become thick. Then onycholysis, the nail plate can split from the nail bed, or you can feel like the nail plate is separated from the nail bed. Then there is something called a salmon patch also that you can see. Now, so psoriatic nails is something that they ask very commonly in the exams. So if they've said subungual hyperkeratosis, nail pitting, oil drop, I think the answer is very easy in this case. The answer would be psoriasis, right? Now, other things that you have to know in nail is that there is something called a dorsal pterygium. It's like the two lateral nail folds are trying to merge in the middle, and that splits the nail into two. So that is called a dorsal pterygium. We see that in nail lichen planus. Then you can see blue lunula in Wilson's disease and ergyria. Yellow nail syndrome. See, derma is a very visual branch. Even if you remember the images and you remember where all you see them, that should be enough. Yellow nail syndrome is something where you'll see not just yellow nails, but you'll also see lymphedema, respiratory illnesses like bronchiectasis, and yellow nails. So not just yellow nails, there is a problem with the lymphatic system and with the respiratory system. Green nails are seen in Pseudomonas. This is a patient's photo. Then Mees lines are seen in arsenic poisoning. Arsenic poisoning, you have to remember there are mnemonics and all for arsenic poisoning in forensics, so you remember it from there. But Mees lines would look like this. Then hypoalbuminemia will have a few bands, one or two lines, which are called murex bands. Lindsay nails are seen in, so I remember like this, Lindsay sounds like a female's name. So she has painted them nicely. Half of the nail she's painted, half she hasn't. So half and half nails. and then you can remember like she has some renal problem or something, if that works for you. Now, Lindsay nails are seen in CRF. The way I remember it is, as Lindsay sounds like a female's name, no? So she painted her nails nicely. Half of them are white and half of them show the background erythema that is supposed to be seen below the nail plate. That is seen because of the erythema, like the vascularity of the nail bed. But Terry is like a terrible guy. So Terry is a terrible guy. He drank so much, he destroyed his liver. So if CLD patient comes to you, they might have Terry nails, wherein the erythema is not that prominent. The nail bed isn't functioning that well. So 10% of it will be pink and 90% would be white. So these were the few nails that you could remember and that could show up on your exam. Now we'll start with the hair section. Now in hair, we have to remember, first when you start learning hair, the most important thing is to remember what all causes of hair fall will cause scarring, and what all causes will not, what all diseases lead to scarring over your scalp, and what all do not lead to scarring. So see, basically, if there is like a very severe infection or something, there will be scarring. But if there's a mild disease that is only damaging the shaft, or that is only leading to hair fall, that won't cause scarring as such. As we'll discuss all of these diseases, it will become more clear for you. The first one that we're going to take is alopecia areata. So in alopecia areata, there's something, the MCQs, I'm only going to discuss the MCQs. So basically, alopecia areata is an autoimmune disease wherein the hair follicles fall off, okay, because of immunity, body's immunity. So that is why we give steroids and all. But the MCQs that you have to remember is, there is a variant of alopecia. You will see round patches like this wherein you'll have hair fall. So there are antibodies against the hair follicles which are making the hair fall in round patterns. So what happens is, most of the time it will resolve on its own, but sometimes you have to give medicine. So we wait and watch for 6 months. If it resolves on its own, we do not give any treatment. Otherwise, we have to give the treatment. That is the protocol. Anyways, the MCQ is, if the entire scalp hair fall off, if the hair strands or the whole scalp fall off, that is called alopecia totalis. And if the hair fall is present all throughout the body, like the eyebrows and the body hair and all, everything falls off, then it is called alopecia universalis. Now, since it's an autoimmune disease, it is associated with a lot of other autoimmune diseases like thyroid disease, pernicious anemia, vitiligo, and atopy. So whenever a patient comes to you, you have to screen them for these diseases. Then you see something called exclamation mark hair. So the hair strand would be thicker at the bottom and it would be a little thinner at the top. So just like an exclamation mark. So you see something like a thick thing here and then this thinning over the distal part. So exclamation mark hair is seen. Also, there's something called sparing of gray areas. So we do not know why, but the disease selectively targets black hair. So all your gray hair would be spared and the black hair would persist. So there's sparing of white hair that we see in alopecia areata. Then there is something called ophiasis. Ophiasis is a pattern wherein the hair fall would be in a band-like pattern. So suppose this is your scalp, you'll see there is hair here, but in a band-like fashion across your scalp, the hair would be deficient. So that is called ophiasis. You can like I've put a nice image only, but if you're confused and all, you can Google it for yourself. We see it very commonly in the clinics. So this is a band-like pattern all across your scalp wherein the hair fall would be there. So that is again alopecia only. So alopecia was an autoimmune disease which was causing fall of the hair strands. Now there's something called patterned hair loss, which is male and female pattern hair loss. So in male and female pattern hair loss, what happens is mainly because of your genetics and because of the hormones, your hair is falling off. Okay. But the best thing is that it falls in a pattern. Best thing I'm saying because it's easier for us to diagnose in that case. Because what happens in males is, from the front part and from the top part, there will be hair fall. We can grade it according to Hamilton Norwood grading. So you can see that the hair fall, see there are 7 stages, okay. You can see that the front side is, the frontal hairline is receding and the crown part is also getting destroyed. And eventually the patient might lose almost completely, the patient might go completely bald from the top. So that happens in male pattern hair loss. The second thing is female pattern hair loss. So in this, what happens is, if this is the partition line, no? So the hair would start disappearing from the center And uh, again, like, you might lose a lot of volume from the center when it progressively worsens. So that happens. Now then, there is something called so there are not many MCQs. You have to remember that Ludwig's grading is for females, Hamilton Norwood grading is for the males, and this is how the male and the female pattern hair fall would look like. I think this is all that they could ask in your exams, but I mean, they ask very basic questions, so we can leave it there only. In case you have any doubts or something, you can put in the comment section, or you can, always put in the queries. Even after the video is uploaded, I'll keep checking the questions and all. What time this I will plan my day accordingly. I think it will go on for like some 3-4 hours, so you can see it. The recording will be available on the YouTube channel, so you don't have to worry about planning your day and all. Now the thing is, when there is this thing, hair cycle, so hair progresses through 3 phases. There is anagen, then there is catagen, and then there is telogen. So all, even though all of my hair look alike, they are not the same. Some of my hair are in anagen phase, some are in the catagen phase, and some of them are in the telogen phase. So what happens is, anagen is like the fresh new baby hair. It's like hair's youth, I would say. Then there's a transition phase where let's say the hair stays for very little time, and then the hair gets old. So 3 months after the hair gets in the telogen phase, it is going to fall off. Okay, so you can remember like ACT, but I don't think they'll ask the hair cycle per se. They'll ask you anagen effluvium and telogen effluvium. That is what you should be focusing on. So anagen hair per se doesn't fall. Anagen hair has to convert to catagen hair, and then that has to convert to telogen hair, and telogen will fall off in 3 months. But in anagen effluvium, what happens is, if suppose a patient takes chemotherapy, radiotherapy, what will happen is, this anagen phase won't be, I mean, the hair strands won't properly be there in the anagen phase. Now, anagen hair won't be proper. When the hair isn't proper, they have a tendency to fall. So hair needs a lot of things for growth. Most importantly, it needs blood supply. But if I take medicines which arrest the growth, which arrest the blood supply and all, so then the quality of anagen hair would be bad. Bad quality hair also fall off. That is called anagen effluvium. It happens when a patient takes radiotherapy or chemotherapy, because that will decrease the blood flow to the scalp. Now there's something called telogen effluvium. If I have a transient stressor, okay, if I am like, I fall sick today, for a very brief while, my scalp won't get any blood supply. So, in a defense, my scalp will convert all my hair to telogen hair. Like, suppose somebody gets pregnant, or they have infections like malaria, typhoid, or they undergo any surgical procedure or something, it's a brief, stressful period. It will cause conversion of all anagen, a lot of anagen to telogen. Now, they won't fall off right away. If I fall sick today, they won't fall off today. After 3 months, they will fall off. That is called telogen effluvium. Okay, then there's something called trichotillomania. Trichotillomania it's basically a psychiatric disorder in which patients have OCD. But it comes under OCD only. So what happens is, patients have a tendency to pluck on their hair. So they'll keep pulling out their hair, and you will see that there is an incomplete loss of hair. So because it is being done by a person, at some places the hair is still remaining, and the hair will be of varying length, because when you're plucking, you can't pluck them with that precision, no? So they will have varying length, and then they will be bleeding around the hair follicles, and you have to refer these patients to psychiatry. Plus there's a test called square window test. So I can shave off a square, I think that is not, I mean, I'll explain. Okay, so you can shave off, you can make a window on the patient's scalp. You can shave off that hair, so that hair strand will be very small. The patient won't be able to pluck it. So the next time the patient comes to your OPD, you might see hair fall over these areas, but over the square window you'll see hair growth, because when the hair strands are very small, the patient won't be able to pluck it. It's called hair window test, in case you want to go and read about it. Then there's something called tinea capitis. So tinea capitis is tinea infection of the scalp. It has been divided into two: non-inflammatory and inflammatory. So basically, when you have fungal infection of your hair follicles, let's say, okay, these are your hair follicles. If you have fungal infection of your hair follicles, the hair like might fall off from, let's say, this area, the hair fell off. Okay. Now, whatever remains are a few dot-like structures. These are the remnants of the hair strands that you'll see. So that's called black dot. It happens with endothrix infection, or when the fungus infects the inside of the hair strand. That's called endothrix infection, and that you'll see in TV. So how I remember it is, see, TV is black. No, your TV screen is black. So black dot tinea happens due to T and V. That is Trichophyton tonsurus and Trichophyton violaceum. And gray patch happens because of ectothrix. When the fungus tends to live over the hair strands and not inside it, that's called ectothrix infection. And I remember it like this, canines, dogs, you might have had dogs at your house. So they have this, they're always salivating and all, no? So I remember it like that. So some gray patch is there when Microsporum canis infects you. So you can remember like black dots would be when the fungus is growing inside. It will appear as black bulges on the hair strand. When it's coating the outside of the hair follicle, you might see like gray patch and all. So grayish color might be there. Also, because canines salivate and saliva dries and becomes grayish, so that can also like help you remember it. Also, because like TV screen's black, so black dot tinea is seen in tonsurus and violation. That is the way I remember it. If it helps you, that's great. Then there's something called inflammatory tinea. Now, what happened here was like the hair strands and all were affected. There was not much inflammation that happened in the scalp per se, but there are certain varieties of tinea that can infect your scalp and damage it. So, significantly. So one of them is favus. I'll show you a picture of favus. So it happens in Kashmiri people who wear cap and all. So when you wear cap, there is yellowish crusting that you see over the scalp. Now it happens in favus, so you pick up the S. S is Schonleni. Favus happens because of Trichophyton schonleni. It happens in Kashmiri people, and there are yellow cup-shaped crusts that you'll see. Can you see there are yellow cup-shaped crusts? This is known as scutula. Okay, so that happens in favus, and there is inflammation that happens here. Then there's something called chirion. This is chirion. You have tender, will be extremely painful, boggy swellings over your scalp area. So chirion has tender, boggy swellings with pus discharge over the scalp, and that is seen in mentographites and verrucosorum. So how I remember it is, if you twist the K, you'll get a V, and from the V you can also make an M. So verrucosorum and mentographites are the ones responsible for chirion. I think you got the mnemonic, didn't you? So K will make V and it will also make M. So mentographitis and verrucosorum, and favus has an S. So scutula, also Schonleni. Favus, the S at the end of favus is for Schonleni and for scutula. Scutula sounds like, spatula. So yellowish cup-shaped crust, spatula, scutula sounds like the same thing only. So yellowish cup-shaped crusting, if you see over the scalp, in Kashmiri people usually, that is favus. Now chirion, tender boggy swelling. Also, this black dot tinea that I was talking about, no? Can you see it nicely here? There are black dots. See, very nice black dots are here. Can you see the nice black dots? So that happens in black dot tinea, which happens due to TV, tonsurus and violation. MCQs would be on the organism causing it mostly. Then grey patch was because of canine, canis. So this is grey patch.